the record button. All right. So today we're going to do our introduction to pathology, which is kind of a tie-in with immunology. We're going to see the transition from immuno to pathology, right? And pathology essentially just means abnormal tissue death. Okay, so abnormal tissue. It could be due to like some kind of enzyme issue, could be due to some kind of disease, right? Because it's essentially pathology is just a study of a disease. All right, so let's get started. So these are all the goals we're going to touch on today. We're first going to touch about the connection to pathology, and then we're just going to go into the basics of pathology, and then finally we'll tie it all together with just some intracellular accumulations and some calcifications that you'll see throughout your medical career. Okay, so the first thing, acute inflammation. We've already tied into this a little bit, right? Whenever you get some kind of infection or some kind of tissue damage, right, you get neutrophils activated. Now, what brings in the neutrophils?
Isn't it the trauma to the tissue?
Yes, trauma to the tissues, but what does a trauma to the tissue do? What does it activate?
It activates the innate immune system.
So yeah, the innate immune system, but specifically the macrophages, right?
Right. Uh-huh.
The macrophages become M1, and that is what ends up bringing in neutrophils because they release that IL-1, IL-6,
A
IL-8,
TNF alpha.
IL-12, TNF alpha. Yes. And this is what essentially allows you, particularly IL-1 and TNF alpha, to bring in neutrophils. Okay.
Mm-hmm.
So that's essentially how this is broken down. Now, that's an email. Okay. Now, with that being said, we're now going to start talking a little bit more about that. So here, this is all review so far. Nothing new right now. You get these macrophages, they get activated. We talked about that. They release various factors. These are those inflammatory mediators. Now, these factors that we talked about increase the vascular permeability. Okay. So that's what things like IL-1, TNF alpha, all those things do. Now, in particular, you do have to know more details about it. Like, what does each one of these factors do to allow them to cause increased vascular permeability, allowing complement to come into the tissue, allowing neutrophils to come into the tissue, and essentially break down the dead tissue as well as these pathogens coming in that you don't want either. Okay. Now, with that being said, we need to talk about two different types of fluids that you can get when you get damage or non-damage fluid buildup. Okay. So the first one is non-damage or non-trauma fluid buildup. Okay. This is just due to fluid leaking across and you having higher filtration than you have of reabsorption. So this is that lovely equation that you guys went over, right? Where the oncotic pressure difference minus the hydrostatic pressure difference. Okay. This is the thing that brings fluid in. This is the thing that pushes fluid out. Okay. And essentially, you should have just a little bit left inside the tissue, which is then brought back in via the lymphatics. Right? Now, there's different things that can cause you could have to have increased filtration, right? There's different causes of increased filtration. One would be if you have increased blood pressure, right? If you have increased blood pressure, that means your pressure difference increases a lot more and you have more fluid being pushed out than reabsorbed, right? Now, the other example that you can have that leads to increased filtration has to deal with a decrease in the oncotic pressure. Now, your oncotic pressure is essentially controlled by your albumin, which is a liver protein. Okay, so these are the two big reasons that you get fluid buildup that's not due to like trauma, not due to an infection. Okay, this is essentially just due to having too much filtration that you overwhelm the lymphatics and you overwhelm your capabilities of being able to reabsorb fluid at the venual end. Okay, good so far.
Yes.
So with that being said, do you expect to see protein or do you not expect to see protein?
So ask the question again.
Do you expect to see protein in this fluid or do you not expect to see protein in this fluid?
Not you. The norm would be not.
Yes, good. So you do not see protein in this fluid because you do not have an increased permeability of the membrane. So proteins are not able to leak out because the membrane itself is still intact. Okay? The endothelial membrane is intact, so proteins cannot leak out. Okay? That's the same thing with cells. Cells will not leak out because, once again, the membrane is intact. Okay? So this is essentially called a transudate. Okay? This is something that, once again, has poor protein, which makes sense because we went through the whole scenario, right? It's hypocellular. Makes sense because cells can't transverse an intact cellular membrane or that endothelial membrane, I meant to say, the endothelial membrane, okay? So if these cells can't transverse it, you won't find it in the fluid, okay? So with that being said, what other big kind of pathologies do you see this in? Things like heart failure,
Yes.
right? In heart failure, you have a buildup of blood backing up into the lungs, backing in to the right side of the heart, backing into the venous circulation, and even backing into the lower veins of the legs, right? Depending on how bad it is. So as it backs up into the lungs, same thing happening, right? You have increased hydrostatic pressure, so fluid pours out of the blood vessels or the capillaries into the extracellular space. Okay. And as a result, you get edema, right? You get that the pulmonary edema, that fluid collection. Okay. So that's the big difference between a transudate and then the next one we're going to talk about, which is known as an exudate. Okay. Whenever you see transudate, it's not due to trauma or an infection. Exudates are always due to trauma or exudates. Or not exudates, but infections. Okay. And we're going to talk about why that is. Now, whenever you get an infection, right, or you get trauma, we kind of talked about this a little bit and immuno, but I kind of glossed over it and I was like, we're going to talk about it again later. So I'm not really going to harp on it too much. Well, now's our connection between the two. This is called the cardinal signs. Okay. So this is what is known as inflammation. Whenever you get any tissue damage, whenever you get any infection, you get these cardinal signs. Okay. Outside of if you have various issues with immunodeficiencies that causes you not to have cardinal signs. Hold on. Let me pause now. Okay, now we're resuming the recording. So yeah, so let's continue. So those are the two big breakdowns when it comes to pathology with the fluid that you build up, right? So there's transidates, no protein, right? No cells, no WBCs in it, due to kind of hydrostatic pressure differences, oncotic pressure differences, and then exudate, which we're going to talk about now here in a minute. Now, so here are the big cardinal signs when it comes down to inflammation, right? You got rubor or color, right? So rubor and color is just means redness and warmth. It kind of irritates me now that I didn't see you guys. Because then what if I get more people and I just don't know that they're there? Let me see if I can change host. I should have just done it with my other pad. Yeah, I don't think it's gonna let me change host. Okay, well, I'm not gonna bother with it anymore. Okay, so anyways, so rubor and color, right? Tumor just means swelling, right? Dolor is pain. And then functional lasset, it's almost like they're like, well, we want 5 things. So what's another thing we can add on there? And the last one is loss of function, essentially. So that's what the functional LISA is. It's essentially is if you have an area that's red, inflamed, swollen, and painful, you don't want to use it like you usually do. And that's why that's in there. Okay. Now, each one of these guys have different factors that play a part in it. Where did these factors come from? This lovely diagram. We're going to go more in depth in this when we do farm, because this is where farm starts to tie in to the pathology stuff and ties in to treating patients. Okay. So here, essentially, this is the breakdown of arachidonic acid. Okay. This is how your body does it. So whenever you get damaged, this is damage. So we're talking trauma, we're talking infections causing cellular destruction. Your cell membranes get damaged, right? And as a result, when the cell membranes get damaged, they release phospholipids. These phospholipids get metabolized or cleaved by an enzyme called phospholipase A2. Now, phospholipase A2 then ends up forming arachidonic acid. This arachidonic acid produces a lot of different byproducts depending on what enzyme breaks it down or what path it goes. So it could go down the cyclooxygenase, the COX pathway or cyclooxygenase pathway, or can go down the LOX or the lipooxygenase pathway. Okay, the COX or the LOX pathway. And as a result, they both have different factors that they produce. So for instance, in the COX pathway, you form things like PGE2, things like thromboxane A2, Okay. You even form things like PGI2. Okay. These are three big things that you formulate via this pathway. And they all have their different functions. For instance, PGE2 deals with vasodilation and increased vascular permeability. Okay. So, in any condition, in any one of these guys above, that you're going to have increased permeability, he's going to be one of those players, PGE2. For instance, warmth. Warmth means there's more blood flow to the tissue, vasodilation, right? More blood flow to that tissue. So, more likely you're going to need PGE2. What do you know? Prostaglandins being PGE2. Swelling. Increased permeability causes fluid, proteins as well, to push out into the tissues. Okay? Now, here with this aspect of it, this is more at the venual end, not the arterial end. Okay? Because if you remember, when we did immuno, we talked about where cells extravasate. Where do they leave the tissue or leave the blood and join into the tissue? Where is that? At the arteriolar end or the venual end? Which side do they enter the tissue? Do cells leave the blood in the arterial end or do they leave the blood in the venual end?
Isn't the venue in?
Yes, perfectly, at the postcapillary venule. So, with that being said, these guys, these leukotrienes, work at those postcapillary venules. Okay, which is why leukotrienes like C4, D4, and E4 are the big players for protein-rich fluid at the postcapillary venules. Okay, all those cells that we talked about, the neutrophils, the monocytes that turn into macrophages, the lymphocytes that want to join in that during the more adaptive phase. This is the guy, and it's all during due to leukotrienes, as well as other factors like histamine and serotonin. Okay. So with histamine, a good way to remember is the type 1 hypersensitivity. Remember, type 1 hypersensitivity is solely histamine at the beginning. So what do you present in the very beginning of type 1 hypersensitivity? What type of symptoms do you present with? Like what type of rash is it? So it's called a wheal. So it's red, it's raised, right? It's warm to touch, right? These are the things that you see when you have a type 1 hypersensitivity. And that's exactly the same presentations of what histamine does. It makes it red, it makes it warm, it swells. And the last one is pain. Histamine isn't really that big of a thing with pain. It's more PGE2 and bradykinin that are for pain. Histamine can do pain, but it's more the first two, bradykinin and PGE2, that deal with pain. Okay? So that's the way I remember what histamine can do. Is just essentially remembering, well, what is a hive? It's warm, hot, and is swollen. Okay? Good? Any questions on any of that so far? No? Okay, good. So, let's keep moving on. Now, this image here, we're going to touch on this again because this is essentially where farm comes into play. For instance, you have someone who has excessive swelling due to a sprained ankle or due to some kind of injury or an infection, right? Let's say you have infection in the knee joint, which is osteomyelitis, or maybe it's inside the joint, like a tenosynovitis or something like that. Anyways, it's going to be red, it's going to be inflamed, right? And it's going to be hot. What do you think you're going to want to do? Use and attack this here, which is why you give them NSAIDs. NSAIDs essentially decrease this. Okay. And as you decrease arachidonic acid going to cyclooxygenase, what do you think happens to the levels of arachidonic acid? If you decrease it going through cyclooxygenase or COX, what do you think is going to happen to the levels of arachidonic acid? This is just straightforward, simple biochem stuff. Yes, it should increase. Now, my next question is this. If you block one pathway, what will happen to arachidonic acid pertaining to the other pathway? So you block it going down this pathway. As a result, what will happen to this pathway?
You say that again, Michael?
So if you block it going down the cyclooxygenase or the COX pathway, what do you think will happen to the LOX pathway?
The arachidonic acid, it it would decrease because that pathway is open and it goes that way.
Yes, so essentially arachidonic acid ends up going towards the LOX and you form more leukotrienes. Okay. This is a pathological thing that you will find out later with aspirin-induced asthma. Okay. Because essentially what's ending up happening is that you block COX and you increase LOX and you end up having an asthma attack. Okay. So just keep it in mind that if you block one pathway and it's a double pathway, the other pathway increases. Okay. To use up all the arachidonic acid. All right, good. Now, let's keep moving on. So, we've already talked about the exudative, or no, the transudative way when you don't have any proteins leaving the blood vessel. The only thing that's leaving is fluid, right? So now we have tissue damage, right? We have various factors like prostaglandins, histamine, leukotrienes that end up causing the membrane of the endothelial cell to become leaky. So now we've actually compromised the endothelial lining. Okay? We've caused the endothelial lining to become compromised. So things can now leave the blood to enter the tissue. Okay? Following along so far. Okay, great. So as a result, you get things like high protein. You get things like cells inside the tissue fluid. And it presents like this. One is clear because there's no proteins, there's no cells present. It's just fluid. Okay? Versus exudate has cells present and proteins present. This is always due to trauma or due to infection. Now, how are they going to ask you a question like this? They'll ask a question like this. They're going to give you the whole spiel on, let's say, someone who has a lung infection. Okay? Get a whole spiel. The person has a fever. You do an x-ray. You see consolidation in one of the lung lobes. And then they ask you, which do you expect to see in the fluid when they do a chest tube to drain the fluid from the chest, right? They could do that exact same scenario with someone who has cardiac failure, and it would be different. Cardiac failure, you'd have a transudate. Lung infection, you get an exudate. Good? And the other one they may throw at you is whenever you get lymphatics involved. So they could throw a vignette at you where they've had chest surgery, and then all of a sudden there's fluid buildup. They do a chest tube, they pull the fluid out, and they find out that this fluid has high levels of chylomicrons and lipids. And then they ask you, what is the most likely location of where this came from? Okay. They most likely damage the lymphatics now. And this is the presentation you're showing up with. Chylomicrons, because of the thoracic duct, carrying the food that you ingested, right, up towards the venous circulation through that thoracic duct. So you nick it through surgery, and now you have this fluid of lymphatics draining out into the thoracic cavity, causing this effusion. Okay, so that's the third one that they could throw at you, is those ones. But these two are the most common: transudate and exudate. I may have seen one question on the lymphatic one, which is known as an emphyema. Okay, good. Any questions on any of that? Pretty straightforward. Pretty straightforward. Okay, good. So now we have tissue damage. So we have tissue damage, right? When you get tissue damage, there's two different ways you can heal. This is after the infection has passed, and now your body's trying to heal itself. There's two different ways. One is via regeneration. The other is via fibrosis. These are the two different ways. Now, what do you think plays a part in determining regeneration versus fibrosis? What do you think plays a part? What factors? Growth factors? No, not really. What else? What do you think is really important when it comes to regeneration and fibrosis? if the tissue can even regenerate, period, right? Good, like stem cells, yeah. So you want to say, is the tissue even able to regenerate? Because you got different tissue types, right? Epithelial cells, for instance, they're highly regeneratable. They they turn over very quickly all the time. But let's say something like muscle. Does muscle turn over? No, exactly. So with muscle, if you had muscle tissue damage, what do you expect to happen? Regeneration or fibrosis? If muscle tissue was damaged, would you expect to see regeneration or fibrosis? So muscle, remember, there's no stem cell capabilities, right? So it has to do fibrosis. That's the only thing it can do. Okay. Versus something like epithelial or squamous cell on your skin, they can undergo regeneration. Okay. Now let's do one more. Brain tissue. Do you think that undergoes regeneration or fibrosis? So if your brain gets damaged to the point that there's tissue damage, brain is made up of neurons, and neurons, are they regenerative? No, CNS neurons are not. You're thinking of peripheral nervous system. Peripheral nervous system, I would say yes, because you have the ability of them to regenerate with the axons, right? But central nervous system, no, they don't regenerate. Okay, so that's why you'd undergo fibrosis. It's a very unique fibrosis, which is known as a glial scar that we'll talk about, or you will talk about when you get there in neuro. Okay, but essentially it's the same concept. Okay, you don't regenerate, you fibrose. If you remember this aspect, it will make everything in the future so much easier if it's going to regenerate or if it's going to fibrose. Okay, now the other factor that plays a big part in if it's regeneration versus fibrosis is the extent of the damage, how big the damage is. So for instance, if this is my skin, right? And I got a giant piece of my skin chopped off, let's say in a biopsy of the skin. Now I'm missing all this tissue here in the center. Some of this tissue will undergo regeneration, right? This will start to grow inwards. This will start to grow inward, and you'll get some regeneration. But eventually, towards the very center, you'll end up, which is what is known as fibrosis. And it's because the damage is so extent that the regeneration was not enough to fill in everything. So you were forced to fill in the rest of it with fibrosis. Yes, just Schwann cells, not oligodendrocytes. Okay, so those are the two factors. One, tissue type. Two, how big of a damage of the tissue is it? Okay. If the tissue is really damaged, more likely you're going to get more fibrosis. Okay. Good. Any questions on those two before we move on? Now, when you undergo tissue repair, there's 4 different stages. Okay. What do you think the first thing is after you notice that you have tissue repair? If you need to undergo tissue repair, what do you think the first thing is? You need to do? Um, so we're thinking about more the detailed things. Scar tissue would be more of a type of regeneration, right? It's a type of fibrosis. Scar tissue is essentially. So the first thing that you end up doing is you have to stop the bleeding, right? That's the first thing you have to do when you're trying to regenerate tissue. You have to stop the bleeding first. So that's what this first one is, which is known as the exudative state. Now, in this phase, we're essentially plugging up this injured area with platelets, okay? And we're undergoing a secondary platelet plug. That's essentially what you're doing. Now, after you form a platelet plug, what do you think is the next thing that's going to end up happening? So you have damage to the tissue, you're bleeding, platelet plug is now here. It has now formulated the platelet plug, so now you're no longer bleeding. But what do you think is now happening next? Yes, macrophages are coming in. Good. Macrophages are coming in. Inflammation is occurring because during that initial damage to the tissue, what do you think came in? Bacteria, viruses, microbes, they all came in. So now you need the inflammation to eat those guys up and destroy them, right? So that's the next phase is the macrophages coming in, the neutrophils coming in, the platelets being activated, and they're releasing their various factors, which is known as the resorptive state. Because now you're trying to heal the tissue and resorb this plug that you have developed. Okay? So you have various macrophages. And I got another picture that has all these guys here. Macrophages, you got neutrophils, you got platelets here. Okay? Now, the big important thing to know is platelets here are releasing various factors. One in particular is platelet-derived growth factor. Okay? This guy is responsible for activating fibroblasts. Why are fibroblasts so important to get activated? What do they do? What do fibroblasts do? They release collagen. They pump out collagen, right? That's what their function is. They pump out collagen. So since they're pumping out collagen, it allows that to then start to reform the dermis layers, if it's in the skin, right? Or the connective tissue layers, if it's everywhere, right? Because everywhere you have connective tissue underneath it. So that is what these fibroblasts are essentially doing. They're formulating that new connective tissue. Okay. Now, from there, you then go into a proliferative state, which is stage 3. So in stage 3, you then start to reproliferate the damaged cells that are able to undergo regeneration. Okay. Now, this is around day 3 to 7. Is this first week, okay, where you have proliferative phase. During this time span, you still have the collagen that was released from the fibroblasts. And to be specific, this is type 3 collagen. You do need to know this because when it's a scar, it's type 1 collagen. Originally type 3, then gets broken down and becomes type 1. Okay? Now, at the same point in time, you get what is known, yes, as wound contraction. So here we have an extra cell that pops up. It's known as a myofibroblast. So what these guys essentially do, myo means muscle or contraction ability, and fibroblast, laying down collagen. So these are fibroblasts that not only have the capabilities of laying down collagen, but they also take one part of the tissue and another part of the tissue and they pull them together. They pull them together and then lay down a whole bunch of collagen. Okay. So that's what this myofibroblast is all about. So this is a guy that is responsible for having very tense skin whenever you have wound repair from burns. If you ever seen someone who's had really bad burns and you look at their skin, that skin is very tight and taut because these myofibroblasts have wound contracted and they've made the skin very taut where it was very elastic. Okay? That's essentially what ended up happening in those individuals. Now, at this point, we also have what is known as granulation tissue. This granulation tissue is the guy that's responsible for making new blood vessels. Okay? Now, the last thing that happens in stage 4, this is just the maturation stage. This is when we take type 3 and it becomes type 1. Okay? This is essentially what ends up happening at this stage. You're taking type 3, changing it into type 1. Now, what do you think is the enzyme that's required, for this? What's the enzyme required to break down collagen? Collagenases, yes, but let's be a little bit more specific here. What's the name of that collagenase? It requires zinc. So this is metalloproteases. Okay, so metalloproteases that require zinc are the guys that are responsible for breaking down the collagen, changing it from type 3 to type 1. Okay, now the other thing I wanted to say was this collagen that you laid down in the resorptive phase, what vitamin is required here? C. Perfect. These are the two things that affect your healing capacity from wounds or trauma. Zinc, with changing type 3 to type 1 and making it mature during the maturation stage, and vitamin C for laying down collagen in the first place. Okay? So if you have any deficiencies in either one of these, you have wound healing deficiencies. Does that make sense? Okay, perfect. So now let's look over this. So we've already said a lot of these guys in the process. So for instance, metalloproteases, tissue remodeling, type 3 to type 1. We talked about it. Zinc is the guy that's important here, right? We already talked about platelet-derived growth factor. What's he responsible for? Fibroblasts. Fibroblast. Platelet-derived growth factor, the F for fibroblast. Okay? It's really hard because all the other ones have F on the end of them, but whichever makes it work, that kind of helps a little bit with me. VEGF, this one is for angiogenesis. Okay? This is also something that is released whenever you get hypoxia. Hypoxia stimulates VEGF to be produced to allow you angiogenesis to occur. Okay? This is one of the main reasons when you run and exercise. This is kind of tie back to year one. This is a lot of reasons why when you run and exercise, the first time you run an exercise, you're very tired, your muscles are hurting a lot, and you don't have the endurance. But after you run the first time, you stimulate VEGF to develop, and you form new blood vessels in muscles so they get more nutrients. So when you run next time, your muscles have more nutrients to them, so you don't have that cramping pain anymore. And that's essentially what ends up happening. Okay. Now, with that being said, VEGF takes, time to develop because this is a gene level alteration, but it happens over a time period of you exercising. Okay, good. Now, we already talked about this stuff. This was in the thing that we were just talking about, right? The inflammation at the beginning with the platelets and neutrophils and macrophages. You have their destroying of bacteria, the proliferative phase, which is the phase after that. That's where you're dealing with the collagen develop with type 3 collagen, with the myofibroblast and them pulling things together, causing fibrosis to occur. Okay, getting that taut skin. Okay. Once again, you can see here vitamin C. And then there's copper, because just like your fellow student was talking about, copper is also really needed for what enzyme? Vitamin C is this hydroxylase, is a very given. But what about copper? Copper is needed for which enzyme in the collagen pathway? Lysooxidase. Okay. He's responsible for taking that copper and helping the tropocollagen get cross-linked and become more sturdy. Okay. So that's what the lysooxidase essentially does. Yeah. Okay, let's keep going. So this here, same thing, just have it written out for you in a different way. Nothing different here. Now, here's the next thing I want to talk about. There's different types of scars, right? So the types of scars you can get is one, just a regular scar. This is when you have repair that occurs, right? And you get some fibrosis in there, but not excessive amounts of fibrosis. Okay. For instance, 80% of it is regeneration, while the other 20% is fibrosis. Okay. Now, the next one is what is known as a hypertrophic scar. A hypertrophic scar is something that you have tons of fibroblasts in, and they produce a lot of collagen. Okay. And this collagen that they produce, right, is type 3 collagen. This is very important because the way they tie this in on a question is they say, what do you expect to see on a biopsy of this? Type 3 or type 1 collagen? Well, since this is a hypertrophic scar, this is type 3 collagen, not type 1. Okay? Because type 1 is only seen when you get the maturation process. And I'm going to show you the two different types of scars. Then the second to last is what is known as a keloid. So a keloid is like the most extreme, where the fibroblasts are so much that the collagen that you're producing is expanding beyond the borders of the wound. And I'm going to show you a picture of that as well. And the last one is this contracture that I also kind of alluded to already. When you get this kind of taut skin, you get skin that gets contracted against each other because of these myofibroblasts. Okay? Myofibroblasts is the reason for this. Okay? And then the way they explain it out is just like this is saying, right? They have a damage or some kind of burn to the hand, and now all of a sudden they can't make a complete fist. What cell was most likely responsible for a reason why this person can't make a fist? Myofibroblasts. Because they're the guys that form this taut skin, and now he can't stretch his skin anymore like he used to make a fist. Okay? Good. We talked about that. So there's a better picture. I'll show you that later. So this here is, once again, just another image of it. Nothing really different here. We're just going to keep moving. Same scenario. The only thing different is, what does suturing do? So essentially, this is showing you the benefits of suturing an image or a trauma. So essentially what ends up happening is this. With a regular damaged tissue, right? You get that gap. This is a gap that you get with trauma. If you leave that alone, right? This is going to start to fill in with regeneration, but it won't fully be able to regenerate, and the majority of it will fill in with fibrosis. Okay? However, when you take sutures and you bring them together and you suture the tissue together, you see how small of a distance now there has to undergo regeneration. So small of a distance that the amount of fibrosis that occurs is very minimal. And this is why suturing is done, outside of the aspect of leaving an open wound and causing infection to occur. Okay, so here's the other example. Okay, this is someone who did not undergo suturing. So you get the same damage. It doesn't fill in with regeneration fully. So you get scar tissue. A lot more scar tissue. Okay, because you have so much space to fill it, which is why you have such a bigger scar. Now, with that being said, this is known primary intention, and this is known as secondary intention. Okay, primary intention just means it underwent more regeneration, while secondary intention means it underwent more fibrosis. Okay. Good. Any questions with any of that? And then just like with anything in life, there's a third where it's mixed. Some of it underwent fibrosis, some of it didn't undergo fibrosis, and it went through primary intention, which is what this third intention is. It's a mix of both. Okay. All right, good. So this here is an example of a hypertrophic scar. So you see how big this scar is, but it's not extending out from the scar damage line or the tissue damage line. okay, versus this individual where he had gotten damaged here, but it had spread well beyond the borders of the trauma. This is known as keloids. These happen more often in African American individuals, which is also very important to know. Okay? They happen more on the face, the earlobes, they can happen on the nose. Okay? That's usually where you end up having these presentations of a keloid. Now, once again, type 3 collagen. Now, the big difference between the two of them is that in a keloid scar, what's going on here is it's not so much, yes, you have the fibroblast producing a lot of collagen, but it's not just that, right? It's also an issue with the breakdown of that collagen, right? So as a result, you also have some presentations of type 1 collagen and type 3 collagen. Because what ends up happening is instead of you being able to fully break it down and have only type 1, you're not able to fully break it down, all the type 3 collagen. So you have type 1 and type 3. Okay? Which is why in keloid is disorganized organization versus in hypertrophic, it's parallel. Okay? Everything is normal and good. You just laid down too much of it. Okay? Versus here in keloid, you laid down too much of it. Plus, you weren't able to break down the excess that you made. Okay? Any questions on these? We good? Yes, no, maybe so. Okay. So let's take a 4-minute break because we're right at 6. And then we'll continue on with chronic inflammation and then the remaining stuff with path. But this is the getting the feet wet, and then we're going to finish this off. Because the remaining of this stuff isn't really that much. The remaining path portions of it. After we get this connection, it's going to zip on through. So let's go ahead and do 4 minutes, come back at 6:05. Sound good? All right. I hope I'm not going too fast for you guys. I mean, we're going to review a lot of this again on Thursday when we go over it again. So, hmm. Okay. So let's go ahead and keep going. So now that we've talked about acute inflammation, we've talked about how you undergo repair, we've talked about the processes of that. Now let's talk about what happens when your body cannot defeat whatever infection it is and essentially undergo repair, right? Because you always have this infection present, or you always have this ongoing inflammation to cause irritation and prevent healing and regeneration. Okay. So let's go ahead and move into this. Is everyone back? We good? All right, good. So once again, since this is chronic, make sure you remember acute neutrophils, chronic lymphocytes, macrophages, right? That's the big difference between acute and chronic. What's the guy that interconnects the two between acute and chronic? Who connects the two? Who's this guy? Yes, perfect. Then the dendritic cell. He's the guy that's responsible for connecting the two together. So now you have chronic. Now, here, just being said, like we've said, you're going to see many macrophages and lymphocytes because this is a chronic setup, adaptive immunity. Now, with that being said, it also makes sense while this would be deemed a type 4 hypersensitivity, right? Because type 4 hypersensitivity is all about the adaptive immunity, right? Now, the next thing we're going to talk about is how chronic inflammation plays out with the different mediators. So you have two different types of cells, right? You have Th1, which we've talked about, and you have Th2. So essentially, how does chronic inflammation present in both of those presentations? So in Th1, what is ultimately released from them? What do they release? Perfect. Interferon gamma. So as a result, when you have chronic inflammation that's Th1 mediated, you're going to see high levels of interferon gamma. What is the main thing that is released from Th2? Yes, 4 and 13. Perfect. So that's exactly what you're going to see interleukin wise, which we concur here. Nothing new here. Nothing new. All old coming from immuno. Okay. The only thing different now is that this presentation is always present. Why is it always present? Because the infection is always there. Right? Because if you remember back when we did immunity and immune cells, the immune system is a huge positive feedback loop, right? Interferon gamma stimulates more Th1 cells. IL-4 stimulates more Th2 cells, right? But there's only a handful of things that decrease negative feedback of the immune system. Do you remember what they were? Do you remember what are the things that decrease the immune response? Or in other words, decrease, like stop the immune response? Because you have all this positive feedback loop, right? So what ultimately ends this feedback loop? Yes, your Treg cells, right? With TGF beta. Exactly. You also have CTLA4, right? That prevents B7 from connecting to CD28, right? So if you always have the infection, CTLA4 is never present enough to stop B7 and CD28. So you always have this going on. Okay, good. Now, we've already talked about the acute phase. Now, with the chronic phase, the other thing I want to talk about is chronic phase leads to tissue changes. What I mean by that is this. Tissue becomes like you will end up getting more glands, you'll end up getting hypertrophied tissue. The actual tissue itself starts to change. Okay. You get tissue adaptation is a good word. Okay. Your tissue starts to adapt to this prolonged infection. Okay. That's why in chronic, you see fibrosis. Because in chronic, your tissue is trying to adapt to whatever's going on. So it's releasing various factors like TGF beta. It's releasing various factors like platelet-derived growth factor that's causing the tissue to undergo fibrosis, causing the tissue to produce more collagen. Okay, good. Now, what do you see at a microscopic level is two different things. Granulomas that have necrosis in the center, or granulomas that do not have necrosis in the center. Okay, these are what is known as non-caseating versus caseating. Okay, now this presentation with non-caseating versus caseating granulomas, they come about because of this. Okay, what ends up happening is when you have macrophages, this is my M0 macrophage. He eats up something. Okay. Let's say, for instance, TB, something that a lot of people know something about. Okay. So he eats up TB in the macrophage now. Now, when it eats things, it becomes M1, right? It releases various factors like TNF alpha. TNF alpha does a variety of things, right? It brings in CD4 cells. It brings in more macrophages, right? Now, when CD4 cells get here, they try to stimulate these M1 cells via interferon gamma, right? However, even with interferon gamma, these macrophages are unable to kill the TB. Now, here's my question to you. Think logically here. If you had a bacteria or a parasite inside your body and you couldn't kill it off, what would you do to prevent it from getting to other people? If you had a parasite inside your bed and you wanted to prevent it from spreading to other people, what would you do? So if you undergo apoptosis, essentially all you're doing is letting that parasite out. You killing yourself doesn't kill the parasite. Okay? So yes, you contain it. You build a little wall around yourself and you lock yourself inside with this parasite. So even if this parasite leaves your body, it's stuck in this wall. Okay? And that's exactly what your body does. It knows it can't kill TB. So it ends up walling this off with a whole bunch of CD4 cells and macrophages. Okay? With a whole bunch of CD4 and macrophages. Now, with that being said, over time, what do you think is going to happen to this cell over time? It has a TB parasite inside of it. Over time, what do you think is going to happen eventually? It'll die. That's where the necrosis comes from. That's where the necrosis is. So that's why you present with necrosis in some of them and not in others. Okay? Because in the other ones, and I'll talk about that here in a minute, in the other ones, it's not so much that you have bacteria, it's more of something that you can't fully digest. So for instance, if a macrophage eats a fiber, let's say silica, and it can't fully digest it, it's just going to have a piece of silica inside of it, but it's not going to just wind up undergoing necrosis. Right? So that's the big difference between this one, which is non-caseating or non-necrotic, versus one that is necrotic. Okay? And the necrotic ones, you'll see in the center, it looks like a whole bunch of death. You won't see any real nucleus because they've died, and the only thing left there is like debris. Okay? Now, with that being said, what do you think is the big thing keeping this wall intact? These macrophages release TNF alpha, And these CD4 cells come in and as well as macrophages, let me make that clear, as well as macrophages come in due to this TNF alfalfa. So what do you think is the big factor that helps with keeping this walled off, with the center being necrotic with the bacteria? What factor? Do you think it's interferon gamma or TNF alpha? So what is the thing that's causing macrophages to come in and become a wall? Because essentially the macrophages are the guys that are making the wall. It's not so much the CD4 cells. The CD4 cells are releasing interferon gamma, yes, which is causing the macrophages to attempt to kill off the bacteria inside of them. But TNF alpha is the big player that's bringing in more macrophages. Okay, so TNF alpha ends up being the reason why you have this wall still intact. Because you got to think, over time, these guys will fall in. They'll end up eating up that bacteria, getting the parasite inside of them, eventually over time, right? So then you'll need new macrophages to wall off those guys. Okay. And that's essentially what ends up happening. It's like a black hole. More and more macrophages get sucked in towards the middle, trying to eat up this TB, and they die off because they can't eat it up. So then more macrophages build up on the outer wall, and then they get sucked in over time. Okay, so TNF alpha is the big player that's pulling in these macrophages and bringing more macrophages to the site of this infection. Okay, because if you remember, TNF alpha does what to the blood vessel? What does it do to the blood vessel? TNF alpha, IL-1, right? It makes it leaky. So then macrophages can come in. What do you think would happen if we were to get rid of TNF alpha? What do you think would happen? We gave them some antibody that bound to TNF alpha and prevented TNF alpha from doing its job. What do you think would happen? No leaky? Perfect. So no new macrophages. No new macrophages means TB will eventually break out, which is what ends up happening, and you get a reactivated TB because you start losing these macrophages on the outside. So it's almost like you're weakening the wall. This wall that you built around yourself, you're weakening it. So then now the parasite can break out of the wall and infest other parts of the lung. Okay. And then is what is known as reactivated TB. All right. That's very important to make sure you know. Make sure you know how granulomas form, what's the main player behind it, how there's two different types, because that's essentially what all this here is talking about. Okay, here you have APCs, they eat things, right? You have Th1 cells. We've already talked about how you activate Th1 cells via IL-12. They release interferon gamma, macrophages come, TNF alpha. TNF alpha is the guy that then forms what is as a granuloma. Now, if it's filled up with bacteria, it ends up becoming a caseating granuloma. If it's not filled up with bacteria, it's called a non-caseating granuloma. So, for instance, this here is an example of a non-caseating granuloma. We know that because in the center, you can see various cells. You see the nuclei? Those are that's what depicts a non-caseating granuloma. Okay, I'm going to show you an example of a caseating granuloma here later. Any questions on any of that? Okay. Now, with that being said, that's chronic infection. So now let's start playing a little bit with how do cells, whenever they get stressed, what do they do? Right? So now we've talked about whenever you can't overcome an infection, you undergo chronic inflammation. Chronic inflammation can lead to caseating or non-caseating granulomas, and you'll also have fibrosis. Right? Now, that's not always happening because you don't always just have an infection, right? You could have other things that happen that leads to stress on a cell. Let me give you examples. Let's say you have an organ. This is an organ, right? And blood flow to the organ. Let's say you start getting blocking up of the blood vessel, which is known as atherosclerosis. Okay? When you have decreased blood supply to an organ, this causes stress. So the organ has to now adapt. Okay? That's one example. Another example is smoking with the lungs. You inhale smoke. This smoke damages the lining of the trachea, the lining of the bronchi, all the way down into the alveoli. So, as they get damaged by smoke, this causes stress. Now, what happens when you get stressed? When it's a little bit of stress, you start to adapt. You figure out ways that you can make it work, right? You're like, oh, well, what I'll do is I will try to study 10 extra minutes while I'm eating because I need to get this stuff done. However, let's say you miss a week's worth of material. Now, all of a sudden, you're really stressed, okay? Because you're really far behind. As you get more and more stressed, right, you get more and more bothered that little bit of adaptation no longer is able to compensate, right? For instance, if you miss a whole week's worth of lecture, you can't get that back. You're just behind, period. You can't catch back up, right? So the same concept here with an organ. An organ will try to adapt to the stress, but if the stress is too much, the organ can adapt, it will undergo apoptosis. It will undergo death because it can't adjust anymore. It's too much. I won't ever catch up. Okay. Now, that being said, I'm not saying you undergo apoptosis if you can't catch up with your material, but like just, work with it and just choose the more important things to study. Your organs can't do that, right? Because everything's important. But for you, death isn't the answer. Anyways, but that's essentially what ends up happening. Okay. So here's the different sets up. We're undergoing adaptation. So once again, this is mild stress. Remember, mild stress. It's just enough to cause the cell to make changes so it can live in the new environment. Okay? So these are reversible, which makes sense. If all of a sudden I come to you and I say, oh, we don't have that test anymore on Friday. Now all of a sudden, there's no rush to study the material anymore. So that 5 to 10 minutes that you were doing instead of eating is no longer there. So you no longer do that 10-minute adaptation, right? It's the same concept. When the cells lose that stress, they lose the adaptation and go back to what they were. Okay? Yes. Perfect. Now, these are the different adaptations they can undergo. They can undergo hypertrophy. They can get bigger. Just like you can eat more and get more bigger, or you can not exercise and get more bigger, or the stress can cause you to get more bigger. Okay? Same concept. Hyperplasia. What ends up happening is you stimulate the stem cells and then they divide more often. Okay? Now, here's my question to you. If you had hyperplasia, what do you think is a big risk with having a lot of cells now dividing and multiplying when you originally didn't? Perfect. Cancer. This is that kind of segue into cancer. Hypertrophy, not so much. Cancer, yes, with hyperplasia. Now, my next question is this. What type of cells do you think undergo hyperplasia versus hypertrophy? Do you think cardiac muscle can undergo hyperplasia whenever you have heart failure? No. Perfect. It's those cells we talked about earlier that undergo regeneration and have the capabilities to divide. Okay? Perfect. Now, the next thing is atrophy. Atrophy mainly happens whenever you have decrease in nutrients to a tissue, which makes sense because think of this. If you have a tissue here, like your organ, like the heart, and all of a sudden you have decreased blood supply, what do you think is going to happen when you don't get food? You starve. When you starve, you lose weight. Exactly the same concept here. These organs starve, so they lose weight to compensate and match the blood supply. Okay? Versus hypertrophy is whenever you end up getting excessive usage of an organ, which ends up causing like hypertrophy of the cardiomyocytes. Okay? That's essentially is only when you see hypertrophy. Is in muscles and like heart, like skeletal muscles and heart. That's only places you really see hypertrophy. Okay? Other places you see more hyperplasia. Nerves, no, not so much. Nerves don't really hypertrophy, but that is a good thought because they can't undergo hyperplasia. So with nerves, what they end up doing is they make more dendritic cells. They make more dendrites. Okay. So they make more connections via that way. Not so much getting bigger. Okay. So with the atrophy, okay, this is undergoing by protein breakdown, the ubiquitin proteasome pathway. Okay. Now, another way that they can undergo it is simply by undergoing apoptosis of various cells inside the organ, which causes the organ in total to atrophy. Okay. So you can either have it at the cellular level, one cell, you decrease proteins, and then that cell shrinks, or at the organ level, where you kill off cells and the organ shrinks. Either way, you have shrinkage of the organ. Okay? Good? All right, perfect. Now, here is now moving on to cancer. Okay, so with this, I'm going to take a minute and we'll come down here. So we've already talked about hyperplasia. Increased stress, increased organ size, right? Decreasing stress, you're decreasing organ size, like that aspect with not giving nutrients. Okay. Now, metaplasia. What ends up happening here is we're taking one cell type and we are changing it into another cell type. So, for example, you can take squamous cells and change them into columnar cells. Okay, this is an example of metaplasia. Okay, and this is essentially due to stress. Now, how do you remember? Is it squamous to columnar or columnar to squamous? Is knowing what type of stress it is. For instance, if you had acid, okay, do you think a squamous cell would be very good for that? Or do you think a mucus secreting columnar cell would be good for that? Acid. Columnar. Exactly. So that's the metaplasia that happens. You take squamous cells and you switch them to columnar cells that can handle the acid. Now, let's say you have very abrasive food that's stuck in your esophagus. Do you think it'd be more squamous cells or columnar cells that are more important here? Squamous cells. Perfect. And this is how you're going to remember it. Do not sit there and remember every single different one. Think about what is causing the issue and stem it from that. What cell is most likely to help protect yourself against this? Acid, columnar cells, smoke, and abrasive things. Oh, that's squamous cells. And that's exactly what ends up happening in the bronchi. Columnar cells aren't going to do nothing against that. They're just going to produce mucus. That's not really going to do much when you have a lot of smoke and abrasive carbon coming down, right? So this is how you're going to remember it. Now, with that being said, is this reversible? Yes, this is reversible. Once again, if it's a stress and you remove the stress, just like you had your adaptation, you can revert back if the stress is removed. Okay? You're just making yourself more adapt to the new environment. However, whenever you start to have actual changes in your personality, you cannot come back from that. Think of it like this: the doctor who ends up killing a patient on purpose, he cannot come back from that. That is a dysplasia. The stress he had can remove. Seeing a lot of patients, which caused him to accidentally kill that one patient, right? The stress could be removed, but that doesn't change the fact and change him moving forward that he killed that patient on purpose by accident. Well, not on accident, but on purpose. Okay? So that's dysplasia. Okay? This is the beginning portions right before you get to cancer. Now, this is non-reversible. And then finally, you get cancer, which is the ending portion. Okay? This ends up leading to cancer. Any questions on that? So, with that being said, this is almost like a forward image into neoplasias. There's two different ways you get cancers. You get it via hyperplasia, which then moves to dysplasia, abnormal cell growth, which then leads to cancer. Or you can have hyperplasia, which leads to metaplasia, which leads to dysplasia, and then finally cancer. These are the two different ways you end up getting cancer. Okay? It's either hyperplasia to dysplasia to cancer, or hyperplasia to metaplasia to dysplasia to cancer. This one you have cell change. This one you do not have cell change. Okay? All right, good. Now, with that being said, there are other stressors. For instance, radiation is a stressor. If you remember back in year 1, you have non-ionizing and ionizing radiation. Ionizing radiation leads to double-stranded DNA breaks, right? And these double-stranded DNA breaks is fixed by what? So ATM picks it up, right? And then it'll either undergo recombination, right? Or it'll undergo non-recombination. Recombination is whenever you have pre-S phase, so you don't have a sister chromatid, and the non-recombinant one is when it's post-S phase. Okay? Now, let's keep going. Okay. So, I haven't yet touched on the apoptosis yet, because I've said it. So far, we've only talked about adaptation. The cells, they adapt and they make it work. They're not essentially undergoing apoptosis. However, when the cells can't undergo adaptation because it's too much stress, right? They undergo apoptosis. Now, this is because they reach this point of irreversible cellular injury. Okay? The big hallmark for irreversible cellular injury is a loss of the nucleus. If you have loss of a nucleus, you are 100% undergone apoptosis or necrosis, but cell death. Okay? Now, let's break this down real quick. This is a rehash to med 1, right? When you went over apoptosis. But essentially, you have a cell. The cell gets damaged reversibly, right? Just a little bit of damage, a little bit of injury. So what ends up happening is you start having hypoxia, you start decreasing ATP because your electron transport chain isn't working properly. So your sodium potassium ATPase isn't working. If your sodium potassium ATPase isn't working, you have high amounts of sodium inside the cell. So what does that do to the oncotic or osmotic pressure? Is it brings in water, right? So now water comes in due to osmotic pressure and the cell swells. Now, here's the stage where you have stress. This is when it can undergo modification and adaptation, right? If it undergoes adaptation, it will revert back to a healthy cell. Now, if it's too much that it cannot undergo adaptation, it will revert to irreversible injury. Okay? And undergo apoptosis. Does that make sense? First, you get cellular injury. At this point where it's reversible, it can either adapt and come back and be healthy or not adapt and die. Okay? If it does not adapt, it dies, and the general presentation of the nucleus has various stages that it undergoes while it's dying. The nucleus first shrinks. A good way I remember this is the cell swells, but the nucleus will shrink. Okay? So here the nucleus shrinks. This is pycnosis, and then it will break in fragment and then finally fade away. Okay? That is the presentation of apoptosis. Now, that's apoptosis. That's not necrosis. Necrosis is always pathologic. This is a really bad presentation because they don't have apoptosis up here as well. So apoptosis is not pathologic. Necrosis, always pathologic. So if you see necrosis, you got to think this is pathological. So how does someone who's undergoing necrosis present? The big thing is this: inflammation. Why? When you undergo necrosis, the membrane breaks, ruptures open, and all of those products inside the cell is now released inside the tissue. The tissue doesn't like that. It doesn't like little bits of lysosomal enzymes eating away at all the other tissue. So it gets red and inflamed. It says, whoa, 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 this isn't right. Let's bring in macrophages to clean up all this crap. I don't like these enzymes floating around. Yes, it's a very messy death, exactly. Okay? This is hallmark for necrosis. Now, cellular swelling, apoptosis. The cell gets big, but the nucleus gets small. Pycnotic nucleus. Okay, I'm going to show you an image of that. Okay, versus necrosis, they just rupture open, releasing all of their debris, and you get inflammation. So, here's my next question to you. Okay, you have tissue that is being targeted by CD8 cells. CD8 cells. Do you have inflammation with necrosis, or do you have apoptosis? With CD8 cells. Do you have apoptosis or do you have necrosis? With CD8 cells, if CD8 cells are stimulated to kill things, is that apoptosis driven or necrosis driven?
Would it be necrosis?
So let's go back to what CD8 cells do. They stimulate fast ligand,
Oh, yes, 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 yes.
or they release granzymes and porphyrins,
That's true. That's
which
right. Yeah.
both end up leading to apoptosis. Okay. So even though it's part of the immune response and is part of cell death, it's apoptosis, not necrosis. Okay. Good. Good. All right. So here it's talking once again, ATP dependent programmed cell death. Okay, you already know the different types, intrinsic versus extrinsic, which we talked about, right? The fast ligand with the CD8 cells, or with intrinsic wise, the BCL2 versus the BAX/BAX. And the BAXs are the pro-apoptotic, the BCL2 are the anti-apoptotic, right? Good. Now, here's a presentation of it. This here is just a diagram I gave you to help you differentiate between intrinsic versus extrinsic pathway. And you can see here, you got the fast ligand, CD8 cells, porphyrins with granzymes, leading to apoptosis. They're going to try to trip you up. They're going to give you an example where there's going to be CD8 cells activated, like a virus, and then they're going to ask you, what do you expect to see on a biopsy? Apoptosis, necrosis, all these other things. Fibrosis, don't get tripped up by it. Make sure you go down to the bare minimum, right? The big picture. What do CD8 cells do? They kill cells via porphyrins and granzymes, so apoptosis. Good. Yes. Now, this here, this last bit, before we get to the calcifications, are just definitions. These are just definitions now. These are definitions that you're going to use moving forward, and definitions that you need to be able to use when you see a gross image, okay, or a biopsy of a tissue that's undergone cell death. There's coagulative necrosis, liquefactive necrosis, caseous necrosis, fat necrosis, fibrinous necrosis, gangrenous necrosis. These are the different types of necrosises out there. We've already pretty much touched on caseous necrosis. Caseous necrosis is that caseating granuloma. So that example we talked about with TB, not TP, TB is an example of caseous necrosis. Okay. So with that being said, what do you expect to see? Macrophages and lymphocytes. What do you know? Macrophages and lymphocytes. What do you expect to see in the center? Well, the cells they're dying and it's necrosis, like he explained, because the cells can't survive in there and they're walled off. So you get fragmented cells and debris. Okay? Perfect. Now, coagulative necrosis. This is an example whenever you cut off blood supply to an organ. Okay? So whenever you have blood supply, so let's say this right here is my kidney. Okay? Blood comes in via an artery, right? And it splits and splits and splits till eventually one artery will supply a portion of the tissue. So whenever you have a blockage, what do you expect to see? You expect to see a wedge-shaped necrosis. That's what you see here. Wedge-shaped necrosis. Okay? So wedge-shaped with the pointing portion where the artery is occluded. Does that make sense? Okay, good. So that's essentially what coagulative necrosis is. Now, on a biopsy image of it, you will see no nuclei. None. Zero nuclei. Because once again, what is the hallmark thing of cell death? No nuclei. Right? So you have no nuclei. However, the general architecture of the tissue is the same. You just do not have any nuclei in it. This is what is known as coagulative necrosis. Okay? Now, the reason why this is because of this. Whenever cells die via necrosis, they can die and rupture themselves, releasing enzymes, right? Or neutrophils can come in and do exactly the same thing. What has happened in this image is that neutrophils have not came in to release and rupture, releasing their enzymes to break down the tissue. So as a result, the proteins that are still left inside the cells coagulate. That's why it's called coagulative. They coagulate, keeping the cell structure. Okay? Now, let's keep moving. I want to show you the next one. Because I want to show you the other one. Liquefactive. Liquefactive necrosis. What essentially happened here is that neutrophils came into the tissue. They released the enzymes, and those enzymes then broke down the tissue. If you have this nice cell here, and now all of a sudden you have enzymes present, they're going to start chomping down on the cells, and they're going to become liquid. Which is why this is known as liquefactive. So liquefactive necrosis is wherever you end up having neutrophils present, breaking down the tissue. If neutrophils don't show up to break down the tissue, then it's coagulative necrosis. Okay? Now, with that being said, there is another type of necrosis that has to deal with this blood supply that is known as pale and red infarcts. So essentially the difference is this. When you get a pale infarct, it's because the blood supply was cut to the organ, right? Whenever we talked about how it branches out, and then eventually you get this triangle, right? And this triangle is supplied by one portion of that artery, one branch of that artery. Well, when you have complete blockage of it, and that blockage stays there completely, then it's pale because no blood can show up there, turning it red. Okay? So essentially, a pale infarct is due to the lack of blood. Okay? The lack of blood is why you have a pale infarct. Now, red infarcts are due to the presence of blood. So, what does that mean? That means this. You have various ways that you can undergo an infarct. One is you block it here. The organ no longer gets blood and it undergoes infarction or tissue death, right? That's what infarction means. The second way you can get tissue death is if it blocks here in the vein versus the artery. Now, if it blocks it in the vein, do you have blood present in this location, in the organ? Yes, you have blood present in the organ. So this is what ends up causing a red infarct. Now, the next question is, why is it infarcting if you have blood there? So the reason why it's infarcting, despite having blood there, is because the oxygen is being pulled out of that blood, right? So you pull oxygen out of this blood. However, this blood cannot move out for more blood to flow in with new oxygen. So as a result, the oxygen becomes zero, well, not essentially zero, but decreases significantly to the point that the tissue can't survive on that oxygen anymore. So it undergoes infarction. And that is what is known as a red infarct. Now, the last way you can get a red, or the other way you can get a red infarct is if you have a blockage like we just had, right? In the first case, you have a blockage. Due to a clot, which causes a pale infarct, right? This is what we discussed. And throughout the process of normal body physiology, we break down this clot. How? How do we break down clots in the body? Plasmin. You remember plasminogen? Right? So plasmin breaks down this clot, and now all of a sudden you get blood flowing in to dead tissue. This pale infarct becomes a red infarct. Those are the two ways you get red infarcts. Okay? And just like we've discussed, with reperfusion, okay, and then venous occlusion, and lastly, if you get multiple blood supplies, which makes sense because it's essentially the same concept with having a venous occlusion. You're not getting enough oxygen switched over and transferred over, so it ends up dying, and you have blood present, so it's a red infarct. Okay? All right. So I'm going to stop there. I'm going to finish off the rest of these necroses and the calcification on Thursday. Here you can see in the center, since I told y'all I was going to show you, there's no cells here, no nuclei. So that's how you know this is a caseating granuloma. Okay. But on the outside, you have all these nuclei. And this lovely guy that I'm going to talk about tomorrow on Thursday. Okay. So, yep. Does anyone have any questions about anything? I'm sorry I went over 7 minutes. We're going to finish the rest of this on Thursday, and we'll go over questions on Thursday pertaining to this stuff, the intro to pathology. Question-wise on your test for CAS 1, yes, you're going to see these questions. I'm not saying you won't, but you're going to see a lot more immuno. The percentage to immuno to pathology is more immuno. Because you got to think, this is just the beginning of pathology. You only have like 3 or 4 lectures on pathology, and that's it. And then you move right into immuno. Okay? So this is important, but really make sure you have a really really ground foundation on immuno before you move on to path and farm and bacteriology. Okay, because immuno, I guarantee you, is a huge chunk of your test. Okay, for CAS 1. Yeah, but we'll finish off the rest of this on Thursday. If you have any questions, I'm here for you and I can answer them for you. Let me stop the recording.